Good day. This presentation is one in a series of lectures on evidence-based practice in nursing. Findings from research in nursing practice have led to several changes in the way nurses deliver care. In this series, we will explore practices that have been deemed obsolete in view of scientific evidence and data. We will also explore what the current thoughts are and what procedures have changed as a result of these evidence. This is part 2 of the Evidence-Based Practice in Nursing series presented by Dr. Tom Madaya. This segment of the series explores the evidence pertaining to the procedure of endotracheal suctioning, where saline is instilled to facilitate secretion removal during suctioning. Thus, the installation of 2 cc's of saline or more facilitate successful endotracheal suctioning and improve oxygenation. This is the question that is the focus of this segment in the Evidence-Based Practice series. It was traditionally hypothesized that normal saline installation thins out and loosens secretions, decreases the viscosity of pulmonary secretions, enhances cough stimulation, which in turn facilitate the evacuation of secretions, and ultimately improve the patient's oxygenation status. However, there is insufficient evidence to support this hypothesis, and the latest research findings indicate that these saline installations are unlikely to provide any benefit and may in fact be harmful. Studies have demonstrated that installation of saline adds a barrier interrupting gas exchange by diffusion at the capillary level. Additionally, the belief that saline thins out secretions have been nullified. Consensus of studies concluded that the installation of normal saline before endotracheal suctioning had an adverse effect on oxygenation as indicated by mixed venous oxygen saturation levels. Results indicated that the time required for mixed venous oxygen saturation to return to baseline values after suctioning was prolonged after saline was used. In addition to increasing patient discomfort during this procedure, installation of saline before endotracheal suctioning also increases heart rate. The change in guidelines and previously documented widespread use of this practice, together with anecdotal evidence, suggests it is timely to re-examine this practice. Current guidelines recommend that routine use of normal saline before endotracheal suction should not be performed. Most practice guidelines no longer recommend normal saline installation into an artificial airway due to the lack of evidence that it helps to maintain airway patency, and it is suggested that routine installation be discontinued altogether due to adverse effects, including the development of ventilator-associated pneumonia. This has been a presentation of Dr. Tom Madaya's series in evidence-based practice. I look forward to your participation in the next topics in this series. Thank you for your participation. As always, please hit the like button, share, and subscribe.